All right, good morning. So the topic here is lumbar spinal stenosis, which clearly is an enormous topic. We have a short amount of time, so I will do my best in a brief overview. The objectives are to review the diagnosis grading system, discuss the limits to the grading system, guidelines for treating, and then an overview of minimally invasive treatments for spinal stenosis. So the classification is you can look at it in different ways. You could distinguish between developmental and acquired. For the most part, as pain physicians, are dealing with acquired stenosis, which is secondary to many degenerative changes, often them layered on top of one another. Additionally, we commonly see lumbar spinal stenosis at accompanying adjacent segment disease, where there is a preponderance of facet arthropathy and degenerative disc disease protrusions as a result of the change in fulcrum from a fusion level. This is a very high incident condition, and it is a condition of the older adult. The most common reason for spine surgery in the United States is lumbar spinal stenosis with neurogenic claudication. There are multiple grading systems which contributes to the confusion. The Lurie grading system defines, I should say all of the grading systems utilize, by definition, the MRI T2 weighted imaging, but they vary slightly in their focus and the sort of the detail of what they are examining. The Lurie system defines the central stenosis based on the thirds zone. So if you look at a sagittal view of the central canal, the Lurie system is going to grade according to dividing that dimension into thirds, and the grades would be according to how far along those dimensions the stenosis is affecting. One of the challenges with the Lurie system is that you have to have a normal to compare against, and so this depends on it being a focused stenosis. If it's multi-level stenosis, then you're not going to have a normal to compare against, so you won't know what your 0 out of 3 in that measurement looks like. The Lee grading system is my favorite because it's named after me. The Lee has 4 grades, and it's based a little differently on obliteration of the CSF that we see at our T2 weighted imaging, which may be a little bit more meaningful. It's definitely easier to appreciate that when you look at an axial view. Grade 1 being no stenosis, which you would see obviously clear ring of white in your T2 weighted image, of course representing the CSF. Grade 2, or 1 and 2, are going to be evident when you start to see less definition between the nerves representing the cauda equina. If they start to become compressed, clustered, and then grade 3, it means that it is completely consolidated. There is no white surrounding ring around the compressed cauda equina nerves. So I think that from my perspective, clinically, I will commonly use this grading system because you don't need a normal level to compare against with this system. The SHISAS grading system is an expansion of the Lee grading system to 7 different descriptors, and I think that's kind of a good place to stop here. The grading systems are challenged because, as I've described, the issue of having a normal versus a non-normal, but additionally, grading systems do not predict the patient's presentation at all. I mean, these studies have been repeated again and again. We can see patients that seem to have clear neurogenic claudicatory symptoms and present with mild stenosis, and also the other extreme. So examining, more than examining, listening to your patient is the key to achieving this diagnosis and directing the patient to the right treatment. The other thing that's challenging is that neurogenic claudication spinal stenosis, when we first hear that term, we think of central canal stenosis. alone, right? That's kind of what your mind moves to immediately, but neurogenic claudication can also be a symptom of lateral recess stenosis and neuroforaminal stenosis. And the difference between those conditions is only evident in listening to your patient. If you see a patient with severe neuroforaminal stenosis, you are only going to know if this is radicular or claudicatory based on what your patient is telling you. So as I mentioned in the previous slide, there is no relation between the degree of stenosis and clinical symptoms. The Zurich Claudication Questionnaire is the standard for objectively defining these symptoms. And I've included the rating scale here. There are 3 versions of this questionnaire, one of them being pain, another physical function, and another is quality of life or patient satisfaction. So this appears to be a valuable measurement for examining the efficacy of your treatments. And also, you'll see this represented in the data on different interventional treatments in our medical literature. Non-surgical guidelines for treatment of lumbar spinal stenosis have been defined by the NAS, the North American Spine Society, and they really didn't find sufficient evidence for recommendation against the use of pharmacologic or non-pharmacologic treatments, but also there wasn't any clear consensus on a strategy for using those. There still, unfortunately, is a little bit of a shotgun effect where you try something with reason and consideration of the patient's individual other medications or their vulnerabilities to side effects that they share with you, and do your best to align pharmacologic modality if you are able to identify one, but there isn't a clear winner in this territory. The Danish Health Authority guideline recommends a couple different medications here for what that's worth. Surgical treatment outcomes have been very well studied. There have been no trials that have compared surgical to non-treatment with placebo or sham. Decompression plus fusion is not superior to decompression alone for pain, disability, or walking ability. It all becomes very muddled. When you look at the data on how to treat with the advanced interventional procedures in this space, there are not ideally designed studies. We do know there is no specific decompression technique, whether it's laminectomy, laminotomy, split laminectomy, laminotomy. There's no one clear decompressive technique that is superior in all terms. Meaning pain relief, longevity of pain relief, function, resolution, or improvement in the Zurich Claudication Questionnaire. Interspinous spacers are slightly more effective than decompression plus fusion for disability. So we do have the data out there that supports interspinous spacers in this area compared to decompression alone. So there is an area for this. The other area that isn't very well represented in the data, but we see every day in our clinical practice, is the negotiation of the patient-specific characteristics, because we know this is a population of patients that is very likely to be presenting with other comorbidities or a philosophy of wanting to avoid over-medicalization, starting with that first surgery that then snowballs into the next. And so that is another characteristic that's really hard to be studied in an objective way. And I think that it is extremely relevant when we're considering this particular area of advanced interventional pain. So the continuum of care for lumbar spinal stenosis has really changed over the last 10 years. Now, non-operative care, as in any other medical diagnosis, is the first preference. And then this is, Vertiflex is listed here. You could also insert mild in this area or any of the other interspinous spacers. There's this expansion between the attempt to treat patients conservatively with reassurance and shotgun approach to different medications, physical accommodations. and surgery, a surgical decompression. There's an expansion in this space, and thankfully we've been able to hear about the mild procedure and see this demonstrated by Dr. Glenn. The Vertiflex is another that could be considered in this area. This is an image of Vertiflex before and after. The concept here is that there is a small titanium spacer that's placed between the spinous processes. There are expandable wings that then straddle the spinous process above and below. There is no anatomical disruption. There's no bone ligament removed. It is an implantation alone. It is also can be removed in its entirety. It doesn't preclude the patient from being able to receive an MRI. It is an incredibly small incision. I mean, we're talking about probably 16 millimeters size of an incision. It's said that this can be done with MAC and sedation, and then you have to consider the tolerance of your patient. The safety profile of this procedure is very good if proper patient selection is adhered to. The wound infection rate is extremely low, and there has been demonstrated to be no impact on sagittal balance, which is a very important consideration when you speak about this procedure with your surgeons, because essentially it's a discrete leveled extension blocker. So it begs the question of, if you extension block, are you going to forcibly cause your patient to be in a flexed position? And that has been demonstrated not to be the case. We do have 5-year non-inferiority randomized controlled trial data here. This is a patient population of nearly 400 that were followed for 5 years following placement of a spacer. And the results are comparable to, a laminectomy alone. In fact, there was a very large study that was done among Washington State patients that demonstrated that the reoperation rate after having a Vertiflex to having a second laminectomy was approximately equivalent, because we all know our pattern is epidural, lami fusion. And so in this group of patients, patients that had a Vertiflex procedure rather than a second laminectomy had the same incidence of then having a further surgery down the road. And the patient satisfaction rate for Vertiflex is extremely high. Because the recovery is incredibly quick. This is an alternative. This is the Minuteman interspinous interlaminar fusion. The approach for the Minuteman is different. The Vertiflex, which you'll see here, is a posterior approach directly axially into the interspinous space. The Minuteman procedure is one which requires just a slightly larger exposure because the device is being placed laterally, which does require attention to making sure that you are situating that sufficiently ventral within the interspinous space. And that lateral approach does have the advantage, theoretically, of avoiding facet joints and the neural and vascular structures. It also preserves the supraspinous ligament, which is offended by the Vertiflex procedure. And then this is coated with, or it is a hydroxyapatite-coated fixation hex nut, so that there can be the bone growth and fusion occurs well afterward. We've just seen the mild procedure. I like this picture because it really gives you a concept of that kind of little alligator mouth that comes in there and grabs a piece of the ligament. This design of the mild is actually quite thoughtful in how exaggerated the curvature is of the end of that needle, which creates such a blunt tip that it is surprisingly, the safety data is really surprisingly reassuring that it does not, as one might fear, have a tendency to grab the thecal sac or launch into the central canal, as you might imagine could occur. As you've heard from Dr. Glenn, the selective criteria for somebody with mild procedure is one who has spinal stenosis with a predominant component of ligamentum flavum hypertrophy. So that is really MRI finding that you need to selectively examine for. It's not commonly reported on our imaging. They may say hypertrophy, but they certainly don't measure the depth of that. So we have to become really familiar with those imaging. The Vertiflex procedure and Minuteman doesn't differentiate between, whether the stenosis is caused by facet hypertrophy or if it's caused by the hypertrophy of the ligamentum flavum, or if it's protrusion of disc. It deals with all of these circumstances. The other consideration when you are weighing the pluses and minuses, specifically with the mild procedure, is that it can be performed at the L5-S1 level, which is not available to the Vertiflex procedure. So long-term safety, this is just a quick slide. The references for each of these are available in the deck, but this is a long-term follow-up from the MIDAS Encore study, which was a prospective multi-center randomized control trial across the United States. And in this trial, 5.6% of patients who underwent the mild decompression, 5.6% of those patients subsequently underwent another surgical procedure. Only 15% of those patients continued to require nerve blocks. Rhizotomy, intrathecal pump implantations were also very low. So what we saw was a reduction in overall need for medical intervention after this procedure. And then across the bottom, you can see the outcome data in regard to neurogenic claudication questionnaire results. These are my references, and I hope you do take a look at them. Do we have any questions, or should we launch into the demonstration by Dr. Nelson? Dr. Nelson in the next room is going to be performing the Vertiflex posterior interspinous spacer procedure. So we have a model. It's a fancy foam model. This is a really common way to have this procedure demonstrated. So that's what you see here. For anybody that wants to go and get trained formally with Vertiflex, this is a lot of times what you'll be learning this upon. Does anybody have questions about the kind of differentiating between these different procedures? Because this is an area, this is a condition that there are a lot of choices, and we have faculty here who have experience with a lot of them. If you want to present any nuanced questions. Yes, in the back, David? Yeah, so the concept, Dr. Pilkington, is that when somebody has neurogenic claudication, spinal stenosis, their response is to bend forward, but they cannot discriminate, right? They cannot, if their stenosis is at L4-5, which is the most common level for lumbar spinal stenosis, a patient cannot themselves just flex forward at L4-5, and so they stoop. And the interspinous spacers, all of them, that their purpose is to passively produce an extension blocker so that the patient doesn't have to bend forward because that's been done for them already. And these are very small devices. On an average, they're 12, 14. How many millimeters is Minuteman? I know the average size for the Vertiflex is 12.
Same. Minuteman's the same size, exactly, as the Vertiflex spacers, from 8 to 16. And, the ligament is not, we use redundancy and hypertrophy of the ligament flavum. It's really redundancy. It's not necessarily hypertrophy. You can get hypertrophy along with the facet capsule and everything else, but it's really stretching it out. Whether you violate the interspinous ligament with the vertiflex, or whether you go anterior to it with the Minuteman or Q fusion, there's been about 20 of these spacers developed. It all provides the same thing. And based on Pete Wong's data that measures the lumbar lordosis from top L1 to the top S1 should be about 50, 55 degrees. It doesn't change the lumbar lordotic angle at all, 1 or 2 spacers. It hasn't been measured for more than 2 spacers.
Yeah. Thank you very much, Dr. Beal. Yeah, so and to Dr. Beal's point, which is a great one, we describe this as hypertrophy of the ligament, but really this redundancy is what we're seeing is it's buckling in. And so if we extend, we're able to stretch that, which is advantageous to the patient. Yeah.
Have there been any head-to-head studies between vertiflex and Minuteman?
No, there have not been any head-to-head study. Are you aware of one?
Nope.
Okay.
And
yeah.
there probably won't be.
Yeah.
Think of where the studies come from. The industry, people complain about industry-sponsored studies, but if there was no industry-sponsored studies, there would be no data, right? So the people in the places like, I don't worry, Mass General, right? Where's all the NIH grants? Where's all the R01 grants comparing Minuteman versus Vertiflex? So this is just not going to happen. But there's just a kind of a shortage of people doing good data. So if you want to do it, if you want to collect your data, as was Dr. Nelson showed, well, that's annoying, huh? As Dr. Nelson showed with his data collection tool, and Dr. Schonner does all this. Dr. Schonner does this all the time. We put registries out, sponsored by societies. I would definitely encourage you to do that.
Yes.
When identifying patients for Vertiflex, I remember reading that they have to have 2 or less levels of central canal stenosis. Is that still relevant?
Yeah, this is FDA approved for 2 contiguous levels between L1 and L5. So this is what happens is we see these patients with the symptoms of claudication and the radiographic findings. You talk to the patient about their preferences for care and the spectrum of options from adjusting their life, trying a medication for whatever that may deliver, an epidural, these types of advanced interventional spine procedures, and ultimately, if they are medically fit, conventional surgical decompression. And then if the patient is interested in one of these in-between advanced interventional procedures, then it becomes a little bit of a exercise in considering the specific characteristics of that person's imaging. Whether it's stenosis at L5S1, there is no Vertiflex. If it's exclusively ligamentum hypertrophy or a buckling, perhaps that's a patient you want to think about mild for. If it's what other considerations do you use, Dr. Beal?
So I like those considerations. My consideration now is let's turn our focus on the lab
We just got it open.
and get that done. So, Dr. Nelson, are you with us? He's not. Okay. So, sorry, Ben. Consideration for picking between spacers and mild. If you have a big redundant ligamentum flavum and primarily central stenosis, that's your mild patient. If you have a combination of central lateral recess and foraminal, which most of the time you do, the vast majority of spinal stenosis is a combination. You don't just have central stenosis. Then you pick a spacer, because spacer will, I do interspinous decompression spacers. I do maybe 1 or 2 a year that have to do with just foraminal stenosis. An elderly patient with just mainly foraminal or lateral recess stenosis. Works. And how does that work? Well, this has been studied. Carl Racin did nice biomechanical studies that show that if you distract interspinous spacer, if you put an extension blocker, it helps the lateral recess and foraminal stenosis to a greater degree than it does the central stenosis. So proportionally, it almost doubles the benefit from the central stenosis in the foramen. And so you use, there's another, in addition to the central stenosis grading system of Lee, there's another foraminal grading system of Lee for for
welcome.
foraminal stenosis, and that's the one that I use too. Going through, we like, I typically use the Shizis or Gwyn system because they're more detailed. Nobody knows these except for people that like us. So Shizis grade C or Gwyn grade G means the absence of fluid around the nerve roots, the cauda equina. If you have that, that's a very reliable predictor of the person being symptomatic from his spinal stenosis or her spinal stenosis. So just remember that. Absence of fluid is what you're looking at. That's for symptomatology. And then there's a little triangle of epidural fat. Whenever that's gone, that's critical stenosis. That means if you decompress this person, sometimes they don't get better.